Hi, my name is Dr. Neil Pandey, and I've been a practicing dentist for the past 26 years. And I've been particularly interested in tooth wear since the beginning, and particularly working it's around 15 years. Mostly into interceptive, non-invasive kind of tooth wear management, which seems to be the right thing to do as per today's protocols. Now, first of all, let's understand why we are so much interested in tooth wear. I mean, we've been seeing caries, we've been seeing periodontal disease, but when we see tooth wear, we see it and we just talk about a night guard or something like that, and that's it. Well, that's not it, right? I mean, we gotta stop if it's a progressive one, and that's why the why. Why are we looking at it? Why are we interested in it is very important, and how and what to do when we see that, I'm going to talk in the pertaining slides later. Now, tooth wear is whatever, it's a non-carious tooth surface loss, right? There's no caries, but there's tooth surface loss. It's a pathological non-carious loss of tooth tissue, also you can say that. It is a progressive loss of tooth surface due to actions other than tooth decay or dental trauma. Same thing said in three different ways. This is one of the definitions by Keller in 1999. Now look at this picture itself. You look at it, you can see, and a lot of youngsters, we see this kind of problem nowadays. Erosion, acid eating away the actually modern food and lifestyle does not look conducive to health. Don't you agree with that? And look at that. I mean, it's all to do with the diet, the habits, and how the patient has been taking care of their oral health in general, and neglect basically sometimes in our part too. So we have to be very careful in that regard. So we have three most common oral diseases, as you know: caries, perio, but now tooth wear is a very, very important now. It's rising, it's challenging, it's confusing, and at times neglected. As I already said, even if we see it, we're like, yeah, it's tooth wear. Did we see it? Oh no, we're more interested in doing implants or crowns and things like that, but we just try to avoid even seeing tooth wear. So it's high time we do that. So in Bartlett in 2019 talked about erosive tooth wear being the third most commonly observed oral condition after caries and periodontal disease. That's a huge thing. So erosive tooth wear being the most common, third. Moving on, and now how to do, what to look for basically is in severe tooth wear consensus that happened in European guidelines in 2017 talked about dividing the two in between pathological and non-pathological, physiological. So physiological tooth wear, that means like tooth wear that happens due to our regular day-to-day munching, eating, around every year around 17 microns per year in maxillary incisor is considered normal. Okay, so but in mandibular incisor it's like around 1.46 mm in a 60-year-old man. If we see a tooth has been lost from the occlusal surface, we should consider that normal. But anything more than that, for example, in a young individual of 30 or something like that, and you're already seeing the dentin exposed and all that, well, that's a big ring alarm bell in your head, right? So this is the basic thing, is how to change between, like how to classify between physiological and pathological. First, we need to understand that. So physiological is anywhere that is within normal limits, and anything beyond that is pathological. Now, it could be progressive, it could be just at one point it has happened and it's stopped now. So that's where the problem lies. When to intervene, we don't know. So that's where I'm going to talk more on the later slides about that as well. So our main effort should be at preserving, preventing, and protecting. So I've actually devised this into primary and secondary as per the guidelines. And in primary, we have preserve, prevent, and protect. So 3 P's, let's say. So we preserve as far as possible by awareness, by habit modification. We prevent by early detection, monitoring, maybe fluoride application, and checking for any salivary discrepancy or any habits, anything that we can, anything that we can do to find the cause and take that cause away from the patient's mouth. So, and protect comes when we can do a little bit of minimally invasive clinical intervention to protect the dentition from further wear. In the secondary part, it comes into, we again monitor, we maintain, and we modify whatever we have minimally the clinical intervention we have done over the period of time. So what we say is, if you look at the scaling is taking away of the tartar, and this kind of tooth wear management when needed is addition of the lost tooth surface into that whatever lost surface and bringing back the lost glory, let's say. And that's best done non-invasive, isn't it, rather than invasive. So in monitoring, of course, we have occlusion also to be taken care of. So occlusion. So now when we talk about occlusion, what we're talking about is mutually protected occlusion. So in mutually protected occlusion, if the patient has lost the canine guidance or the anterior guidance by the anterior teeth and the back teeth start rubbing against each other, we see tooth wear at the back, right? And of course, there are skeletal classifications, various from ortho side, which also tells us about various occlusal discrepancy causing and being the problem of tooth wear. So sometimes ortho is equally a very, very important part in tooth wear management. Now, in monitoring also, when we talk about the monitoring part, one of the most important thing is to have records so that we know what it was before and where it's heading towards. So photographs, one of the easiest things nowadays with smartphones and all that, you can just take a simple photograph also, or you have a proper intraoral camera, proper DSLR cameras taking photographs and keeping records and trying to, but it's very not too accurate. So what will be accurate will be the cast in the sense, ideally digital cast, because there are softwares now which help you measure the teeth 1:1 as well, or there are some AI software which is being made, which is already there, which actually tell you between the two different scans how much tooth wear has happened. Or simply just take a impression and just digitize it. Just take a simple impression, make a model and digitize it and keep it in a digital format. That is also another way to do that. Another thing is even radiographs. In radiographs also you can appreciate if the tooth wear is there. So always when we see radiograph, just don't look at the caries or periodontal disease, bone loss, but just start looking for loss of tooth structure as well in your radiographs. That's a good practice already. Yeah, I've talked about tooth wear management software as mentioned earlier. Now, another way is the basic tooth wear index, which is also there. BEWD is there. We need to, it's a good recording tool. Does not give you full on detail, but it is a good tool at least to start monitoring where we are. It's a good tool for communication between doctors, dentists, and record keeping. Now, first of all, as a dentist, we are detectives. We wear our Sherlock Holmes hat and try to figure out why the tooth wear is happening, where it's coming from. So, as we know, there are abrasion, nutrition, erosion. These are the basic tooth wear. Of course, abfraction has always been debatable, but abfraction is also one of the reasons due to flexion of the CEJ causing the enamel to flick off. So that is a part of the parafunction again. So ideally, any tooth wear, when you look at it, attrition, erosion, abrasion, and abfraction being one. And once we be a Sherlock Holmes on finding what is the cause of that, we try to eradicate, being James Bond. So Sherlock dentists, we gotta be Sherlock Holmes first, and then James Bond try to fix if there's parafunction, figure it out, how to. Now, parafunction is such a big topic. You cannot just get it out of patients' habit just like that. So, and that may not happen at certain time. For example, during COVID, patients were so worried, so much of in stress, they kept grinding teeth, and we have seen tooth wear at a massive rise post COVID as well. So, parafunction is a very subjective thing, and to safeguard it, tight guard could be one of the things, awareness could be one of the things, and in parafunction also you have awake bruxism and sleep bruxism. Now, awake bruxism is when the patient is even during daytime, just people play with their jaws, just with their tooth teeth when they're thinking, or even when you go to the gym, you see people like grinding their teeth away, and then immediately after that they just have lime water or things like that, which again erosion component it brings in. So acid again is a big cause of tooth wear. It's mostly erosion, and most of the food today is acidic. Another thing we can talk about is saliva. Now, saliva, if the buffering capacity of saliva is reduced, then also we see erosive tooth wear in patients. And on top of that, faulty toothbrushing and teeth as a tool, nail biting, and so on, or opening a bottle or whatever, and hard food, as in our context, in our part of the world, there's a lot of hard food being munched, like hard cheese or something like a areca nut. So that's another thing. So we gotta be James Bond to eradicate those things after Sherlock Holmes diagnoses what is the cause of all that. All right, so basic thing in everything is finding the cause. Then next on we can move on. Yeah. So another cause could be a faulty toothbrushing. Patients, I normally tell them an example of a comb, and if we have a comb with a dust, like dirt in it, you give it toothbrush, will you go sideways or upside down? And they just get it, so it's ideal way of teaching them how to not to faultily toothbrush, as well as all the hard food I already discussed about. And yeah. And when we talk about acid, a lot of times we don't talk about pickles. Pickles are equally acidic. They have sometimes a pH of 1. There are some patients who are basically munching on chapati with a pickle in between them. So just imagine a sandpaper along with a erosive chemical. So tooth wear, another way of tooth wear is there. Of course, a lot of times we see people say, oh, you keep on prodding, and what could be the reason and all that. And they say, oh yeah, I have lime juice every morning. Like, how many of them? Like, I keep drinking because it's considered really good, right? It's good, but when it's not in moderation, of course it has issues. And of course we have all the drinks. Everything is acidic, and not in moderation. It's a problem, isn't it? So that's where we are. So a lot of these kind of extrinsic acid intake can cause tooth to bathe in acid and demineralize. Another aspect is also our gastric acid from the inside. So people who have problems with the acidity and all that, regurgitation, like getting mouth acidic, heartburn and things like that. So those guys also have very acidic mouth, and chances of tooth wear or erosion particularly is very, very high in these kind of patients. One of the things you can easily tell about acid reduction is simple flush your mouth. After every meal, after every drink, after everything, if patients start flushing their mouth with simple water, which is of pH 7, we may help our saliva to buffer these things much better and faster. Okay. For example, if you take an orange, it'll takes around an apple, it takes around half an hour to 45 minutes for the pH in the mouth to come back to normal. But if you just flush that with water immediately. It will help in bringing back that normal pH much faster. Another thing in these kind of cases, in this tooth wear management, in erosion, in thing, is also fluoride application. Fluoride application tends to make hydrofluoroxyapatite, which is more resistant to acid damage. So that may also be another help in acidic patients. Another way of looking at tooth wear is very simple chemical and mechanical tooth wear. Now, in chemical goes intrinsic and extrinsic, basically talks about acid and the salivary deficiencies. So intrinsic could be salivary deficiency and gastric causes that causes, and extrinsic could be acidic food and drink, which causes mostly erosion. Chemical causes erosion, whereas mechanical is intrinsic is normal function. When we are by like chewing normally, teeth never touch when we are chewing. Do you know that? Like there's a food in between. Only time teeth touch is during when we swallow, and that's a very light touch. With that much of touch, tooth wear is not possible, right, in the mechanical sense. But when we see that, that means there has to be some kind of extra force there, and that is parafunction. Parafunction is basically beyond function, like grinding or any form of clenching and bruxism. This is a big problem and very difficult to treat as well, and that normally causes attrition. Whereas extrinsic side, we have abrasives like toothbrush abrasion or rough paste, the toothpaste, which is very rough, higher, finer filler particle size. Those kind of things also help in creating more abrasion. And of course, habit as well is there. So whenever we see these kind of abrasion, erosion, abstraction, intrusion, so first thing should be our dynamic restorative cycle. As I already mentioned about pathological and physiological wear, depending on the age of, even in our treatment, we have to be very careful, first of all, to do a age-based treatment. If you see a 1 millimeter of tooth wear in a 20-year-old, it's a big red alert. I mean, okay, we gotta really monitor it well, and if it's progressive, we gotta do something immediately. And something could be nothing invasive, like cutting the tooth and giving a crown on every tooth, which could be detrimental in the long run. It could be monitoring, intercepting with things like bonding and adhesives and things like that. And depending on the thing, if a person is very old, then maybe you'll go into another modalities like little invasive thing also. So basically we have to follow the restorative staircase, where a virgin tooth should be maintained virgin, if demineralized, pit and fissure if needed, fissuring, sealant, and composites first, and if it goes more deeper in the root canal and all that. So basically this is a restorative staircase, and the main thing is to become naturomimetic and minimally invasive. Comprehensive dentistry should be our motto here. Let me take you to one of the cases where this patient came to me with sensitivity and difficulty eating. He could not eat anything basically because there was a lot of tooth wear. The photographs are not that great because I was not too good at taking photograph in 2009, and we just took just photographs and all that, and then I put some composites in his teeth to just mask the tooth wear. And guess what happened? Like, in that case, it could have been erosion and attrition combination there. Most of the times that's what happens with acidic and intake, as well as the attrition because of the grinding. So he had lost complete anterior guidance, lateral guidance. So I created that by simple palatal composites we put in there. So this was after 10 years, this is how it looked. And of course there were many visits, regular monitoring, and at times you do see some kind of like composites coming off and all that. So you add in more composites there, and it's pretty simple. It's like additional dentistry whenever you need it. So there is nothing has been cut, nothing has been touched. It is all addition. This is after 10 years photograph, where of course I'm seeing some kind of in the margins we are getting the fractures and things like that. So it can be easily replenished, right? And let's consider this as a night guard. Okay, you give a patient a night guard, and he or she, or of course us also sometimes, it's so difficult to wear. But if you put a night guard, a fixed night guard in the patient's mouth, that is with your composites and all that, that's a compliance. So he doesn't have to worry. Now, the day one I put those composites in patient's mouth, his tooth wear has stopped. Basically means the natural tooth from wearing has been prevented. So it's a conducive thing for the patient in the long run. So the same patient in more 13 years follow-up, of course, the guidance is there, maintained, but of course we're seeing some kind of a marginal gap between the tooth and the composite. So that's there. That is there. That is one thing you have to keep polishing, keep monitoring, keep things. With the new techniques, it's becoming easier, much better, but this is how it was done then. So this is another case where she came with another similar tooth wear, and the upper completely gone. We just did a composite. This was a lab made composite thing without any prep, just an impression, and the lab made the composites based on the smile design principles at that time. And then we got this going. This is 2016, this is 2018. So it's been going on fine, and now finally this was 12 years follow-up. In 23 the uppers are staying, but of course there is little wear here and there. Just imagine you've given a crown in this patient, although you would have cut the tooth, you would have had more and more possibility of erosion, attrition, all those things are there. So basically now we have bought 12 years from this patient's dentition, and now if needed a crown, we can always do that. And we also gave one implant in this patient. So but on the lower we had done nothing. So 2018 we're like this, 2023 we're like this. We have lost a little bit of, this is monitoring, right? So we have lost a bit of tooth structure around. So now finally we are in the process of doing a little bit of tooth wear management on the lowers as well. This is another case where we had done the similar thing. Patient came in, we did do this with a centric relation, Facebook transfer and everything, and absolutely over the period she's fine, she doesn't want to do anything there, but we did do additional of the where it was lost. This is an example of how we keep the records. We scan, we keep the records, and we can take another scan after some time, and between the two scans you can actually monitor how much tooth wear has happened. If it's progressive, it needs some kind of treatment. If it's not progressive, sometimes all you need is monitoring, close monitoring. Another case of the anterior wear in a patient with GERD, acidic reflux, where we just did a simple this is how it is. We did a injection molding technique where we designed the lower teeth in software, followed by 3D printing of that in an alternate tooth technique, and then we made these kind of night guards, and then through that we just created teeth with one by one, and with a Teflon and everything, one by one. And this is how it was made later, and this is how the patient looked at the end, right? It's not too bad. I mean, of course, the most difficult part in here is the interdental cleaning of the composites, and that's what takes most of your time. Each tooth takes around 20 to 25 minutes. So you give a long appointment to the patient, and that's the way forward. Another case where the patient came with a similar problem with a collapsed bite and the tooth where basically because of the loss of guidance and iatrogenic. So if you look at it, he has a lot of wear at the back. This is not due to just but due to a faulty crown on the lower, and like this one, which was rubbing against that as a sandpaper and eating away, and similarly vice versa, this was also being done by the upper crown. So first took an x-ray OPG. In OPG also you can actually appreciate tooth wear around the area along with other things. We did a comprehensive treatment for this person with the crowns and all that, and removal of the third molar, and tooth wear management, where we also did an injection molding technique, and from there to now there we reached, and followed by that we did a onlay on the posteriors. These are zirconia onlays cemented with a resin modified glass ionomers. So this is a new case. It's been ongoing. This is being monitored very closely. So this is how it is done while cementation, just trying to make sure teeth incidentally it'll be easier to clean. And then this is how the patient's dentition looks like now, and we are in the monitoring phase of how these zirconia onlays would do. These are completely non-prep. All the cases I've shown you so far, there's no preparation at all. Another similar case, a patient had this kind of bite. We just created that with composite, again injection molding, and even the shape of the lip changed. These are other techniques which I had done in the past, but in this case we had to, patient did not like it had gone pretty well, but patient was not living here and wanted something more definitive, and here we had to go on the patient's demand. But ideally I would not go with that. Ideally I would just, if the patient is being monitored closely, I would naturally not cut any of the tooth structure. But there are times when the tooth is completely gone, like then you need to give something like a lithium disilicate crowns to patients like that. But you don't give this when the patient is 30-40 years old. You give this as you graduate. This patient must be around 60 years old. Another case which came just the other day, and this is a challenging case for us. This of course goes for a full mouth rehabilitation with prosthodontist. So that's what we did. So now, what is your Sunday morning take clinic message or Monday morning take clinic message? Is start looking for tooth wear, just like you look for caries, gum disease, and cancer. Take a photo when you see one. Find the cause. Make patient aware. And is it within physiological limit or is it pathological? Understand that, figure that out, prevent further wear, preserve tooth structure, and protect it. And of course, monitor with digital analog cast photographs, maintain, modify if necessary. Tooth wear is a dynamic process and needs to be monitored closely at least every 6 to 12 months. Before we do any definitive procedures such as crowns, bridges, or implants, we must check correct occlusal health, just like periodontal or caries or any other lesions. Be a holistic dentist, not just a one-tooth operator. Thank you, everyone, and last but not least, it's a teamwork that makes dream work. In this team, I have periodontists, orthodontists, prosthodontists, oral surgeons, general dentists, oral medicine pathologist, and pedodontist, everyone. So be a holistic dentist, work in a team, and teamwork makes dream work. Thank you very much.